My name is Shannon Stroud, student ID 24223131. These videos were recorded on the 27th and the 30th of September 2013. The purpose of this video is to demonstrate 6 common airway management skills in accordance with AV's clinical work instructions. These include placing the patient in the lateral position, the triple airway maneuver, inserting an oropharyngeal and a nasopharyngeal airway, use of the laryngoscope, and applying assisted positive pressure ventilations to an unconscious patient.
Placing the patient in the lateral position. First, kneel at the patient's hip. Place your support underneath their head. Place their far arm right out from their shoulder, their near arm across their chest, and their near leg flexed at the knee. Grasp them at the hips and shoulders and gently rotate. Place their leg towards their head, keeping it at a right angle, and their arm flexed also. A common error of this is not on the triple airway maneuver. I start by positioning myself at the patient's head and placing support under the patient's neck. To perform the head tilt, I rest my right hand with my thumb pointing towards the patient's nose on their forehead and my index finger and thumb to slightly lift them to hold the mandible. Applying gentle pressure on the forehead, I will slightly vertically lift the mandible, and this will assist in opening the mouth. To perform the jaw thrust, I'll place my last 3 fingers underneath the mandible, my index fingers on the tip of the mandible, and my thumbs on the cheekbone. Applying pressure back, I'll slowly lift and push the mandible forward, and this will assist of direct visualization into the larynx. A common error of this is hyperextension of the neck when performing the head tilt. This can result in occlusion of the airway as it bends the airway.
Oropharyngeal airway. The patient has already got support from the previous skills. To start, you measure the correct size by measuring from the corner of the mouth to the temporomandibular joint just below the earlobe. First, you lubricate the OPA with either the patient's saliva or some water. You start to insert the OPA towards the patient's palate, and once you're halfway in, you rotate 180 degrees until the OPA is resting nicely against the patient's lips. You have to ensure that the tongue does not get caught between the teeth and the OPA. Once it's in, you must check for breathing or a gag reflex. One common error of this is inserting an OPA which is too small. This will not adequately depress the tongue, or if you insert an OPA that's too large, it may cause an obstruction. Insertion of an MPA. First, select the correct size by measuring from the corner of the nose to the earlobe. Then, lubricate the MPA before insertion. Check the patient's nostrils for obstruction and select the widest nostril to insert the MPA, with the diameter being smaller than the actual nostril. Tip the nostril towards the eyes and start to insert with the MPA following the natural curve of the nose. Rotate the MPA anti-clockwise and clockwise 45 degrees until it rests gently against the patient's nose. One common error of this is inserting the MPA even though obstruction is felt. This should not happen as it may cause further damage to the mucosal lining.
Laryngoscope. First, start by positioning the patient appropriately, supporting their neck and assisting their head into the sniffing position. This will assist with direct visualization of the larynx. Then, check your equipment, ensuring the bowl of the laryngoscope is secure and working. Place your right hand supporting the patient's head and applying gentle pressure to assist them into the sniffing position. Insert the laryngoscope down the right extreme side of the patient's mouth, looking from left to right for any foreign body obstructions. The use of suction may be required. Put the tip of the laryngoscope into the valvular groove. If the vocal cords cannot be seen, simply remove the laryngoscope and reinsert into the valvular groove. Once inserted, apply gentle lifting pressure without angulation. One common error of the laryngoscope use is using the laryngoscope as a lifting technique when it should be more of a pull and up. This can cause trauma to the patient's mouth. Ventilations to an unconscious patient at a rate of 12 breaths per minute. First, position the patient appropriately and insert an OPA. Then ensure you have the correct valve size for the patient, placing the valve with the pointy end towards the nose. Ensuring that you have an adequate seal, placing your last 3 fingers underneath the mandible and your thumb and your index finger over the mask, cupping it onto the face. I will provide 1 ventilation every 5 seconds. While I'm doing this, I'm checking the chest for adequate rise and fall to assess whether the seal is adequate. A common error of this is not maintaining an adequate seal, as this will result in inadequate oxygenation of the lungs